Welcome to On the Subject of Cancer, a podcast brought to you by New England Cancer Specialists. My name is Jessica Fidalgo, your host. Today, our guest is an incredible lady with a very impressive title, Nuclear Medicine Technologist Kersti Lavoie. While the subject is cancer, this is a podcast about people. Every episode, we sit down with someone who's lived through or is a specialist in the treatment of cancer, and we ask them questions about their experience. If you're listening as someone who's been touched by cancer personally or through someone you love, you're not alone here. Let's get into today's conversation with Kersti Lavoie. Thank you so much for agreeing to do the podcast.
Thank you so much for having me. I'm really excited about it.
It is exciting. It's a great chance for me to kind of get into a different area of the center that I don't always get to talk about. So
yeah, absolutely.
I'm excited to dig into it. And we are recording this as it is just about the 1-year anniversary of New England Cancer's opening of our radiation therapy center at Rock Row. So we have lots to talk about. We'll get into how great the space is and just everything that we're doing there.
Absolutely.
One of the first things that I remember doing when I started my job at New England Cancer was going to tour the center as it was just being finalized. And there was this team of scientists installing the 30-foot thick, wall, which is like
excessive, doesn't it?
It almost did. I was like, is this really? We need this? It's like something out of Indiana Jones.
It's really cool.
Okay, we'll make sure we talk about that because I think people will be surprised and interested to hear how that works. But I think we'll just start out talking about your role at NECS and kind of how you got into it. I understand that you used to work as a phlebotomist.
I did.
And then you made this move into nuclear medicine.
Yeah, absolutely.
So how did that transition come about?
So I was kind of trying to figure out what I wanted to be when I grew up. Outside of college, I was taking my general courses. I was working with New England Cancer Specialists in 2014 as a phlebotomist with my mom, actually.
You're kidding.
No, it was really cute. I loved getting to work with her. It's the only time in my life I've been able to do that, and it was really fun and so educational, and really was key. I found in hindsight, in doing what I'm doing and being successful in what I do, I needed those phlebotomy skills and that patient interaction. So that was 2014. Kind of was still trying to figure things out. I actually really wanted to be a radiation therapist. Mm-hmm. And so I kind of started to gear myself towards that. And then the radiation therapy program closed. And I'm like, well, now what? Mm-hmm. So lots of Googling and just trying to figure out what I wanted to be. Came across the Maine College of Health Professions website, and they were offering nuclear medicine. And I was like, oh, that's kind of cool. Went and did a job shadow and just fell in love with it. And so that kind of was the gateway into what I was doing. Went full time in that in August of 2015. And so I had to say goodbye to New England Cancer Specialist and say, you know what, I'm doing this journey. I can't be working. They were wonderful and super understanding, or come back whenever. And then, so I've been working in nuclear medicine since then.
Ever since.
And then when my physicist was kind of brought into New England Cancer Specialists to kind of help mitigate things, he's like, I think I have the perfect tech for you. And he had mentioned it to me prior, and I was like, I would love nothing more than to circle back, come full circle, and work with this company again.
That's
because
amazing.
I knew how wonderful that they are and how great they were to work with, but now I had a different set of skills that they didn't offer yet.
Yeah.
And so for them to be like, please come back, was really cool. And I've thoroughly enjoyed every minute of it.
That's terrific.
Yeah.
So how long did it take end to end for you to complete the training that you did?
So I had a bunch of general credits, which was kind of over a couple of years. But I started the nuclear medicine specific program in August of 2015 and then wrapped that up December of 2016.
Okay.
So it was a really fast-paced program. I went through the summer, but it was 18 months in total for the degree in nuclear medicine.
Okay.
Yeah.
That sounds challenging.
A lot of math.
Yeah, a lot of math.
A lot of math.
As someone who can't even do the tip in their head, I'm very...
It's funny because, they teach us all this math stuff in the program and everything to pass the boards, and then you never use it again. I'm I'm doing basic addition and subtraction in the day-to-day. That's the extent of it. So yeah, it was great. It was a really great program. They've unfortunately closed since then because they just weren't graduating enough people. It was only me and one other student when I graduated.
Really?
And then the year after me, there was one student, and they're like, we can't keep this. It's not profitable.
Yeah.
Which is understandable, but it's a really needed trait for sure.
Yeah, that's too bad. Maybe something else will emerge.
I know. Well, I
our
hope so,
area?
because right now the closest one is down in Massachusetts.
Yeah.
And, then you take into factor out-of-state tuition and everything. We're just not producing more technologists.
Yeah,
So
yeah.
we're needed for sure.
I think there's issues like that across healthcare
Oh my gosh,
in Maine,
yeah.
unfortunately.
Absolutely.
So I think, we talked a bit about the phrase nuclear medicine.
Yeah.
And I think that can be pretty intimidating for just the word nuclear. If people can
Absolutely.
pronounce it, which they can't always.
It's easier than radiotheranostics.
Yes, it is. It's much easier. I think that term is a little maybe confusing or intimidating, or people
for
maybe
sure.
not sure kind of how it applies to medicine or what it is. So what can you tell us about that?
Yeah, absolutely. And I think because nuclear medicine is such a little field in the grand radiology scheme, it doesn't get much attention. And, people come in and get x-rays and CAT scans all day long, but they are like, ooh, I don't want to get radiation injected into me. Like, that's terrifying. Like, surely that's got to be bad. But it's a really cool branch of radiology. We don't look at anatomy like all the other modalities do. We're only looking at body function. So I'm looking at blood flow to your heart muscle to make sure that you don't have any blockages that are going to lead to you having a heart attack. I'm going to look at if your gallbladder is emptying and filling the way we expect it to make sure that that's patent and doesn't need to come out so it doesn't cause issues down the road. I do a lot of bone scans to see if, especially in oncology, to see if cancer has spread outside the primary. But it also has this therapy aspect to it where we don't have to take any pictures. Within my scope, New England Cancer Specialist, we're just treating the cancer. And this is like this new emerging therapy that they're finding a lot of success with.
Yeah.
And is just, it's so new and up and coming, but really like cool and exciting. And like to see the success we're seeing with it is just phenomenal.
That's so great to hear.
Yeah.
So that's kind of like the basic overview. What can you tell me about how nuclear medicine differs in the way it treats cancer versus like chemotherapy, which maybe people are a little more familiar with? Or
Absolutely. Yeah. So this new like radiotheranostics concept is to treat what you image. And so the way it works is the medicine I'm injecting, while it is radioactive, it's targeted. It actually is going to adhere to the specific membrane of the cancer cells. And so if a cell doesn't have that membrane on the outside of it, it just ignores it and leaves it alone. And anything that doesn't stick to those specific cancer cells, patients will, it essentially breaks down over time or it gets peed out. So most of it stays within the body, and it's only going to attach to those cancer cells that we want to target.
That's incredible.
It's
So it's
so
very
cool.
it's very precise.
It's absolutely, precision medicine for sure.
Yeah, that's one of the kind of umbrella terms, I guess,
Yeah.
that it falls under. So so that's incredible. So you're saying that it's targeting cancer cells, but even more specifically than that, it's like able to actually sort of target the membranes or the structure of the cell itself?
Yeah, absolutely. So our cells have like this outer membrane on them, and they all those membranes have like different surfaces, if you will. So think of it like a key fitting into a lock.
Okay.
It's only going to turn and fit into specific ones that are designated for that key. So if it doesn't fit, it doesn't match the membrane's outer cell membrane, then it just ignores it, leaves it alone. Chemo isn't able to differentiate between that. So when you give chemo, it is unfortunately taking out healthy cells and unhealthy cells in the process, which is why patients feel like trash.
Right.
With this new targeted therapy, because we're only going after the bad guys, patients feel fine.
Yeah.
I mean, they do have restrictions put in place afterwards, but fatigue is a really common one. We see that across the board in just about everyone, but otherwise, patients don't even know what happened. Wow. I mean, if it weren't for the fact that they were there and witnessed it, they are pretty oblivious to the fact that it happened at all. Wow. And it's quick, too. Some chemos are like an 8-hour ordeal. You take the entire day to do them.
Yeah.
My patients are in and out in 20 minutes.
Incredible.
And feel great.
Yeah.
And
so can you explain a little bit more about like the different types of, you refer to it as the medicine that you're injecting.
Yeah.
So how do they go about, or do you go about deciding what type of medicine is part of the nuclear medicine that you're administering?
Yeah. So the type of medicine varies based on several different things. The radiation that we use currently and has been, FDA approved and everything is specifically just for men with metastatic prostate cancer that's castration resistant.
Okay.
And those are the only two. We offer 2 different drugs now for that diagnosis. And Pluvicto, the one that has really kind of blown open the gates on like this targeted therapy, is kind of a one-size-fits-all medication. Everyone gets the exact same dose across the board, unless they have like a dip in lab values we don't love, then we can give a one-time reduced dose. But otherwise, I don't have to do any calculations or anything. But that's currently the only diagnosis we can treat with it. But that is going to be changing, I imagine, in the near future.
Amazing.
Yeah.
So is it, for Pluvicto, for example, is that a number of treatments over a certain period of time? Is it one and done? How does that work?
Yeah, so Pluvicto it's called a half-life, in that its potency is cut in half every 6 days.
Okay.
We consider a full life 10 of those. Okay. So 66 days roughly is how long Pluvicto will be considered radioactive in the body. We do 1 injection every 6 weeks, so that right when it's starting to peter out is when we kind of re-up it. And we do that 6 times, provided all the lab values are good, the patient's responding well, it doesn't have enough side effects. So in total, it's supposed to be 36 weeks, but they do get that kind of 6-week break in between. And usually after that, they get another pretty good break from treatment too, which is nice because they're sick of coming into the hospital setting all the time or outpatient clinic. So yeah.
And at New England Cancer, it's all on an outpatient basis.
It is, yeah. We're actually, as far as I'm aware, I think we're the only place that doesn't offer it in the hospital setting, which has been amazing. Patients love it. The parking's great. They're not interacting with other people, coughing and sneezing, getting seen for other non-oncology things, and they're in and out really quick, which is, again, great. They're sick of navigating the just giant hospital systems and trying to figure out what elevator means what and goes where.
It's very patient friendly in terms of kind of wayfinding and things like that at Rockrow so far.
Yeah, absolutely. They roll in and roll out, and they know the drill. It's great.
So Pluvicto is for prostate cancer.
It is.
And so from what I understand, I mean, even after just the very first treatment, you probably patients are like having blood drawn, and then you're looking at those values to see sort of, is this having the effect, and kind of, and it's within days, hours of that first treatment that you can see kind of these effects?
Yeah, sometimes it's a little bit challenging. We do lab work at least a week prior to the next treatment so that we know that there's not a toxicity component from the radiation. Once in a while, we get patients who have either had radiation in the past or have existing issues, and it can cause like a decrease in platelets. Your kidney function can fluctuate a little bit. So we keep an eye on those for the toxicity aspect, but the only real glimpse behind the curtain as to whether or not this is working is to check a PSA or the prostate-specific antigen. Even though that's still not the whole picture, they really have to go and get rescanned to see if their treatment is working, which is really hard for patients because they're like, I want to know if I'm doing this and we're making headway, and that is challenging. But we do like to see the PSA start to downtrend eventually, although sometimes they do get a little spike throughout the treatment course. And if we don't see one, usually after treatment 4, then the oncology team reconvenes and says, well, maybe we rescan and just make sure that we're going to continue to give this patient radiation for a good reason.
Right, that makes sense.
But otherwise, the scans are really the tell-all.
That's what tells you what you need to know. And we're doing all that right at Rockrow as well.
Yeah, right at Reyes. Next door, they're doing our PET CT scans for us over there. It's a specific PET CT. We're looking for that membrane that the Pluvicto will stick to.
Yeah.
So that's what they're scanning for over there.
Incredible. So are there other types of therapies that we're offering at Rockrow in the Radiation Therapy Center that are not, and that fall kind of outside what you're describing?
The only other therapy I offer currently is another treatment for men with prostate cancer, and it's called Xofigo.
Okay.
A little bit different in its mechanism of action. It's still a targeted therapy, but it's really only good for if the cancer has spread to the bones.
Okay.
If it's traveled elsewhere, it's in the liver or lung or has gone to other places, Pluvicto's a little bit better for it because it can treat the visceral stuff, whereas Xofigo is more bone based, and so we do offer that. It's not as popular; it's been out for a while, but there are studies out there that have shown that there's really good success, especially with starting with Xofigo if you can catch it in time, and then down the line offering Pluvicto, and the two together work really well, so they can have both.
Okay, wow, incredible. So, do we see, currently a lot of patients who may have been trying other types of therapies in other settings or at other healthcare providers? And
absolutely, for sure. Most of which have started with an ARPI. Mm-hmm. That's still a requirement as of right now for Pluvicto, that you have to at least be on one of those to get qualified, if you will, for it.
You mean for your insurance?
Yeah, for insurance purposes and just for like treatment success. They like them to kind of be coincide with each other. A lot of chemo, though, is typically first line, but now they've changed it so you can offer Pluvicto as a first line defense. We can let chemo take a back seat and not have to be the first treatment.
The first thing you try.
Because there's so much success with Pluvicto.
Yeah.
Why should we make people feel like garbage? And so it's nice to still have that option and put it in the back seat. But now I'm starting to get more and more patients that haven't even done Pluvicto. Chemo. They're chemo naive.
They just skip that whole process.
They just go right to me, which is great because then they're like, okay, this disease is manageable because the treatment is fairly easy. I mean, it's annoying to have to come in every 6 weeks and get blood work, but as far as, comparing it to the side effects of chemo and the toxicity and issues that can arise with that, people seem to have a better rate with it.
Okay. Well, let's talk a little bit about what it looks like, for patients kind of on the ground, so to speak.
Yeah.
So they come into the center at Rock Row.
Yeah.
There's a great staff there who I've interacted with many times.
Aren't they so lovely?
They're lovely. I just met a patient this morning who just kind of couldn't even stop talking about how great they are and what a good experience he's had there.
Them.
I know. So they come in. They don't. They haven't been there before. They don't really know what to expect. Talk me through kind of how it goes.
Absolutely. So patients always encouraged to park right outside 15 Rock Row. We've got our own parking lot over there, so you don't have to worry about even the parking garage. You come right in the main entrance. You're going to be greeted by Sophia or Riley. Love my girls over there. They are top notch. And then I come and get you right from the waiting room. Mm-hmm. Once I get you from the waiting room, we're going to go back to my room. I just have a very plain room. A lot of people expect it to be all leaded up and look very scary and intimidating, but it just looks like an office exam room. It's very anticlimactic. And I have an infusion chair in there, so they're comfortable. Not that they're there long. And they can bring somebody with them. I think a lot of people think they can't bring a loved one or a significant other. But as long as the person isn't of childbearing age or pregnant currently, they're welcome to come in and they can interact with me and ask the questions they need to ask. They can be there the whole time if it makes the patient happy and that's what they want.
Nice.
A lot of times I see the wives sitting in the waiting room and they're like, I want to get up so badly that I know I shouldn't. And it's like, I always encourage the more ears, the more eyes, the better, especially because they're going to be helping the patient through it. But once they're in and we kind of review all the radiation safety stuff, answer any questions they might have. The process itself is really just starting an IV for them, which is a small one. I don't need an emergency room sized IV.
Okay.
I'm a really good stick thanks to those phlebotomy skills. And once the IV's started, I just hang a little bit of fluid for them to keep that IV open and working because I'm actually going to step out of the room and I work really closely with the radiologists who are contracted with New England Cancer. Mm-hmm. They're primarily out of Central Maine, so I've known them and worked with them for a long time, which was another meant to be moment for me. And whoever has rotated down there will come in the room, make sure the patient had all their questions answered by me, sign consent, And then I just give them the medicine over 1 minute and they're done. I take out the IV and they're on their merry way.
Incredible.
It's short and sweet.
Yeah.
They're almost like all that to do and that's it. Like there's not fireworks. You're not wearing an astronaut suit. Like it's so simple.
I'm not becoming the Hulk.
I know. They're like, are you sure that's even radioactive? Like this seems too good to be true. Like, what do you mean I don't have to take off like the entire day to make this event happen?
Yeah.
So there are restrictions in place though for the radiation safety aspect, especially with Pluvicto. It's a pretty good amount of radiation they're getting. It's the right amount for them, but we don't want to share it with loved ones.
Sure.
So we ask patients to sleep alone. Don't share a bed with your significant other for 3 days afterwards.
Okay.
We want them well hydrated, sitting down to use the bathroom, and really just try to stay out of the general public for at least 3 days after you receive it, just because you don't know who's pregnant around you, and we don't want to give radiation to those that need it. Although most of it stays within the body, they are kind of emitting it like heat, if you will, and so it's being given off from them. That's not to say that the loved one that they live with is not safe to be with them. We just want them to keep distance from them.
Sure.
Every additional 3 feet they can put between each other gives them half the exposure.
Okay.
So, and I have lots of people who have been married like 40 to 60 years, and they're like, I can't give her a kiss goodnight or a hug goodnight for the first time in 60 years. Like the audacity.
Aww.
That's not the case. I don't need them locked in the room for 3 days.
Yeah.
You can still give each other a hug and a kiss goodnight if you need to or want to, but just make it really short and sweet. So, yes. little forehead kiss and then bolt out of there. So I think a lot of people see it as like an isolation and or like a germ that's going to be spread to their loved ones, which isn't the case.
Right.
It's all contained within them. They can't spread it unless they get pee on them. But otherwise, it is really safe. We just don't want to give exposure to those that don't need it.
Sure, that makes
so
total
that's why
sense.
those precautions are in place.
Does the same go for like pets in the home and things like that?
That is one of the most common questions I get whenever I do like my first initial encounter with patients. And we just consider pets as humans as far as interactions go, especially if the pet are older. Don't let them sleep on the bed with you, which is oftentimes more devastating to the pet than the patient. And I'm like, how do you explain to your poor dog that I still love you and will take you on your walkies, but you got to just wait a few days?
Yeah.
And so, just keeping as much distance between pets as possible is really encouraged, especially if the dog is young or on the smaller side. We want to give as much space as you can just for their safety. Oftentimes, if they were to have any effects of radiation exposure, it would be so far along down the line that it would exceed their lifespan.
It wouldn't really make a difference.
But we're also not in the business of giving radiation to those that don't need it. So
that makes sense.
We consider pets in the same umbrella as people, in that at least 3 days for pets. We have a 7-day window for kids. So those 10 and under, grandkids especially, is always a big one, especially in the summer. Is when can I see my grandkids again? So 10 and under, we do say a week if you can. And then pregnant women and infants have to be a full 15 days away from them. And that's just because their cells are dividing so rapidly, growing so fast that they don't want it. That exposure is it's a lot. And the cells are very susceptible to this exposure.
Honestly, in my house, we consider pets the same as human beings too. So that does make sense to me.
Absolutely, yeah. We want to take care of our fur babies.
And so what about protection for you as the nuclear technologist? Is there anything special that you're having to do to protect your own cells while you're administering treatment and at work?
Yeah, absolutely. So the only thing that I do in addition to wearing scrubs is I have a little ring that I wear, and that tracks my exposure to my hand because I'm handling the radiation. And then I also have a little clip that I put on my shirt that just monitors my exposure to the rest of my body, because they have different limits that they can receive based on the regulations. And those readings get uploaded onto this app now. It's nothing's pen and paper anymore. And it tracks how much exposure you get over time, but also how much you're allowed to have per quarter, per month, and all of those are really closely monitored. I worked in nuclear medicine full-time through both of my pregnancies without any issue. My exposure is always really low because I'm with them for such a short duration of time. And It's really only like the last 5 minutes that I'm even in the room with them. And I'm sure patients will notice and tell you that as soon as I give them that medicine, I don't stand very close to them anymore. So I also use like that time and distance as my best friend to make sure that my exposure stays really low and safe. If it doesn't, if we start to see it creeping in the wrong direction, we'll address it.
Yeah.
It hasn't ever happened.
So far.
Yeah, absolutely.
Hopefully.
It's not going to. But yeah, so there are different levels that you can achieve. And if you exceed like a level 1, you'll just get a little note letting you know that happened. You exceed level 2, then there's going to be some action taken. But I work with a really great team who monitors them. And I also monitor my own personal exposure as well to make sure that over the lifetime I'm doing okay.
Right. So it's essentially like would you call it like a Geiger counter? Is that what it's like?
It's called a dosimeter.
A dosimeter.
And it has like it's basically absorbing whatever exposure you're absorbing so that it can give an accurate read.
Okay.
And that is just, again, it's digital now, which is great. It used to be something that we had to mail in every month, and then we'd get a new one, and we'd send in for that month, and then we'd hear about it a few months later, and it'd be like, well, too late.
Kind of too
like,
late,
we've
yeah.
already done that. And that's still a really common method of doing it, but with the ones we have currently, they're instantaneous. I just push a button on the side, and it uploads to an app on my phone. Wow. Tells me how much exposure I had. Yeah, it's really cool.
So we have on staff, I know, dosimetrists.
We do, yeah.
And we have physicists. Can you talk about the ways in which those roles like interact with what we're doing?
I don't work actually at all with either of the ones that we have on staff. The only physicist I work with is through PCI.
Okay.
And so he kind of specializes in this nuclear radiation. And so dosimetrists and the physicists we do have are pretty much all radiation therapy.
Okay.
And so I don't do much interaction with them aside from the fact we live in the same building.
Right. In the lunchroom. You
Right, exactly. we pass each other in the hallways, but otherwise, I'm kind of a one-man show over there, other than, support from my physicians from Central Maine, my support from the outside physicist. And now we're going to have support through research.
Yeah, which is very exciting.
I'm so excited about that.
Research is definitely an area of NECS. I'm eager to get some more
my goodness,
podcasts to kind of dig into that, because I'm someone who's curious about science without actually being competent or knowledgeable about what I don't know. So
absolutely. But the more people we can educate, the more we can take away this really big scary stigma of what these treatments are. I was just telling a patient yesterday, I'm like, I really wish there was a way to educate people on this and talk about it without it sounding so big and scary at first. But you really kind of have to start with the big and scary and scale it down to, it's fine, you're going to be good. We just have these in place to protect our loved ones, and it's going to work really well.
Yeah, and I'm sure it must come as a huge relief for people who have done the gauntlet of chemo and felt so crummy from that to know that this is just such an easy and simple process in comparison.
Absolutely. My patient yesterday, he was new. His wife was with him and so scared. And she said, if he stops breathing, will you resuscitate him? And I thought, oh my God, of course. But also, that's not going to happen here. It's going to be so boring.
Yeah.
The patient didn't even know I gave it to him. I was talking to him the whole time, and he's like, okay, so when am I going to get the treatment? And I was like, it's done. You missed it. I promise you were there, but you missed it. And they're like, he was like waiting for some type of side effect because he reacted so poorly to chemo. Like he said he felt like his chest was going to explode. They had to call EMS. Like it was really, really traumatic for him. Yeah. And so when they came in, obviously we're apprehensive and wanted to make sure that in the event of an emergency, of course we would do that, but it wouldn't transpire.
It doesn't come up. It doesn't
ever happen. We're not going to let that happen.
Well, that's a really good primer on how on what kind of what patients can expect from the experience. So for you, you're coming in on the day-to-day, and your experience, it sounds like, is probably pretty much the same routine with each patient.
Yeah.
How many have you got them lined up like planes at LaGuardia? How many are we talking here?
I do now, just because I'm only there so many days a month. I work full time at another facility, and so I'm only there every other Tuesday right now, offering these treatments until we can expand and increase
Scale up.
So it does vary a lot, though, based on how many patients are in the program and who have finished, and so it has a lot of fluctuation. I mean, at the beginning of the year, I was doing like 4 of them a day. But when I'm here next, I'm doing 12, and that's a full day. That's every half hour I'm seeing somebody starting an IV, injecting, rinse and repeat over and over again.
Yeah.
So glad to be able to offer it, though, for sure. But it is a little bit like planes at LaGuardia, and that we are every half hour on the dot as much as we can be.
I understand we run a very tight ship over there. We're keeping it on time. We're keeping it moving.
Sure as heck try, but I don't know if you've noticed, I like to chat a little bit. So that's really hard for me. But now patients just know to expect me to be a few minutes late because I'm chatting. And in exchange, they're going to get that extra few minutes too.
And they'll get to chat. So it all evens out.
Absolutely.
That's good. Well, so you've worked with patients kind of in a variety of ways throughout your career. And I know you mentioned that you come from a medicine family. At least you mentioned that your mom also was in phlebotomy.
Yeah.
What about the rest of your family? Do you have anyone else who's got a medical background or who's working in medicine?
Yeah, actually, my husband is a nurse as well. He finished school probably 3 or 4 years ago now. And so he started as an ICU nurse and did that for a few years. He's working in an outpatient setting now, which he loves because that means no nights, weekends, or holidays for him. So yeah, I think my mom, like being in phlebotomy, is kind of what geared me towards it because I saw how much gratification she got out of it. And I knew that I wanted to work with people, but I couldn't really figure out at what capacity. So yeah, it was a really good fit. And my husband, I think, is kind of the product of me being in medicine because I was coming home showing him how satisfying and like I can't even put into words like how great the patient experience is to be able to offer that and love what I do so much.
Yeah.
So yeah, I was really happy that he also went down that road, and I imagine that maybe one of our or 2 of our kiddos will hopefully go down that road too because they have a lot of compassion in their little bodies already.
I'm sure. That's so great. I do not come from a medical background at all, but so far one of the best parts about my job too is also getting to talk with patients and just kind of, hear their stories and, be able to connect with them on that level because everyone's just had such a different sort of journey. And
yeah, is this your first time like working within like the medical capacity at all?
A little bit, not 100%, not at all. I don't know why I said a little bit. Prior to this job, I worked for Maine Health as a simulated patient. I don't know if you. Oh my
gosh, how cool is that?
Yeah,
it's
a very cool modality. For the listeners who don't know, it's basically there was a very famous Seinfeld episode where Kramer got a job doing this.
It's true.
And
yes.
And they gave him gonorrhea for the med students to diagnose. So,
multiple times even.
Multiple times,
Poor guy.
So I used to joke about that a lot when I was doing that kind of work. But I have a theater performing arts background, so
cool.
I knew a lot of people in cities I'd lived in that had done that kind of work, and I thought it sounded fun and cool. So I got laid off from the ad agency I was working at during the pandemic. And it just so happened that my son's best friend is the director of the simulation center at Maine Health on Brighton Avenue. And I hit him up and I, trained with the team over there, which is amazing.
Yeah.
And got into it. And it was incredibly gratifying for me.
Oh, for sure.
And I think really set me up to be interested to work at New England Cancer because it satisfied a lot of my curiosity about science and medicine and learning, but without
tapping into your background.
Exactly,
yeah.
and not having to actually put any needles into anyone or see anything scary.
Yeah, absolutely.
One of the best things I did towards the end of that tenure before I started this job was a grant-funded program going out to rural Maine hospitals to do birth simulations for emergency scenarios.
Which is becoming so needed because so many of these birthing centers aren't producing the numbers to justify staying open.
Exactly, yeah.
It's scary.
So important to keep those skills sharp, in case something does come through that they need to handle. And so it's a combination of kind of actor-patient simulation with mannequins.
Yeah.
I did a lot of stuff with these mannequins, which are pretty amazing in terms of what they can do in the technology that goes into building them.
Absolutely.
And it was amazing. I got to see parts of Maine I'd never done before and meet all sorts of people. And especially working with medical students and residents who are, really kind of on the verge of launching their career and are still very hesitant maybe about I did scenarios where, they learned to break bad news of a terminal diagnosis or all sorts of other things,
Imagine. Yeah.
And they just were so grateful to have that experience and to be able to get that under their belt to feel like now I'll know better, kind of how
those
to prepare.
rural healthcare settings too. And New England Cancer Specialist has this as well, has the most special patients in them because they're so grateful that not only that you're offering care, but you're offering care in their community.
Oh, yeah.
And that is critical because patients who needed, these therapies that we're offering, we're all getting deferred down to Boston. And as Mainers, we all think like Boston is like the god of medicine, but we also have like the ability to bring it here and keep it local. You don't have to drive all the way down to Boston. I'm treating patients that live in Fort Kent.
Yeah.
They sure as heck don't even want to drive to Westbrook, let alone Boston. Yeah. And I met patients that before we offered the program said that they were going to defer treatment. They weren't even going to get the treatment they needed because it meant going down there.
Yeah.
It's scary. It's big. It's intimidating. The driving sucks. It has all these cons and like negative connotation, and you're in these huge facilities just hoping to God that you get to the right place at the right time.
Right. You need a GPS to like navigate the hallways.
Right. And so the patients are just so grateful. So grateful.
I love
and
that.
It's just you can't get that everywhere.
Yeah.
I've worked in the big hospital systems. I've actually worked at 7 different hospitals in Maine now. And the ones in the rural setting and the ones at New England Cancer Specialist are the ones where it's just like, man, they couldn't defer a bad patient to me if they tried because all of them are just like, they've got a terminal diagnosis, but that doesn't have to be like big and scary, and it doesn't need to take place out of state. They want the comfort of home and being local and knowing they can pick up the phone and get their provider or at least their team. And even my patients, I give them my cell phone number. Send me a text if you have a question. You're gonna get through this, and you're gonna get through it with really good care.
Yeah. I feel good about that too, as someone who works there. I love that. Boston level care close to home is something we talk about a lot in the marketing department.
And we still we have Dana-Farber. We use them. We access information and tap into them. I've been able to go down and visit their nuclear medicine department and see firsthand how they operate and take some points from that to apply it here. And so it's not like they're getting lesser care, which I think is kind of this
stereotype
that we get, we're too far north to get care up here. We offer the basics and nothing else, and that's not the case anymore. We're really changing that narrative.
Yeah, I love that. You're really a huge part of that, so pat yourself on the back.
I'm gonna give myself some flowers.
So I know you mentioned just the patient, interacting with patients and that whole experience being just so hugely gratifying as part of your job. But do you have a story or a person that stands out to you as you look back on, everyone you've interacted with that
Absolutely.
would make for an interesting story?
I wish I could just sit here and talk about my patients that day because they're all so wonderful and all have this really great backstory. But the one that stands out the most to me is somebody who just wrapped up their treatment. And when I met him, he came in for his first treatment and he was doing the wall surfing because he was trying to hold himself up. He just felt bad. His color wasn't great. He was already feeling super defeated.
Yeah.
He's a lobsterman out of New Hampshire. That was his livelihood. That man had lobster in his blood. He was so passionate about what he did and how much he loved it. And he thought for sure he was going to have to hang that up. And he was going to have to put away his Grundens or whatever it was and be done with it. By treatment 1, he was feeling a lot better. By treatment 2 and 3, he was getting his traps ready. He was talking about getting bait and everything. By the end of the treatment, he had over 200 traps in the water with more to come. And he had entered the treatment thinking he was done being a lobsterman. And we were able to give him so much pain relief, improve his quality of life so much that he was able to not only continue to do it in some capacity, but pretty much at full capacity.
Right.
And he thought that was not ever going to happen again.
Oh, wow.
So to be able to give somebody something that they love back so much, sure, it was a job for him, but I don't think that you could take that job from him if you tried.
Yeah.
He would still dabble in it. So that was really special that we were able to give somebody not only their career back, but something that they loved and were passionate about.
Yeah.
It would be like somebody trying to take away nuclear medicine from me.
Mm-hmm.
Not going to happen.
Or someone tried to take Oreos from me.
Oh my gosh, yes. I would never do that to you.
I'm really not an Oreo right now. That is so lovely. New lease on life. I mean, that's what it's all about. I think that does sound incredibly gratifying.
Especially because like nuclear medicine for the most part is like the imaging diagnostic piece of it. And I don't ever get that follow-up. I get, I oftentimes know what the results are going to be before the report is even read because I've been scanning and doing it for so long. But I get a lot of satisfaction like seeing the progress too.
Yeah.
I mean, when I first started the program, I had a patient who came in a wheelchair for treatment 1 and he left treatment 6 walking out of there.
Unbelievable.
And it's just crazy like to see that firsthand really working and they feel good while it's working. Sign me up.
Yeah,
Absolutely.
They must just be incredulous. That is so impressive.
Yeah, I had a patient just a few months ago too who they were worried that he was one of the ones that had his PSA start to trend up and they thought, oh no, it's not working. Went in and has PET scan and they had no evidence of disease. Wow. It was completely resolved to a point from the Pluvicto, but also like the PSA needed to be addressed, but in a different setting. So when I can also get like the scans and like the visual proof, like, yes, we're doing exactly what we should be for the right people. Priceless.
It's all right there.
Yeah.
Well, so, I mean, I know cancer isn't all, happy. Yeah. And with your husband working in the ICU, you guys obviously have 2 kids and I think animals. Do I understand that? What's the animal count at the
well, we've got 2 turkeys. We have 14 ducks, 11 chickens, 4 dogs, a Russian tortoise, and my husband.
That's awesome. That's good. That's a nice array.
A little bit of a homestead going, and I don't do any profitable thing with it whatsoever.
Right.
It's all just money loss, other than sometimes I sell the chicken eggs.
Well, it's free entertainment. You can't discount that, I'm sure.
We call ourselves Freeloaders Farm because all of them are just living there rent-free, living their best lives.
So that's probably a good source of kind of decompressing and
for sure.
self-care for you.
Oh, absolutely.
Is there anything else that you guys do, to kind of make sure you're taking care of your own mental health side and your own
for sure.
emotional?
I think, for my husband and I both being in the medical field, we also have a pretty decent commute. We live in the central Maine area, but work either on the coast or down south. And so it's kind of become habitual that he calls me as soon as he's out of work. And then we just kind of decompress about our workday on the phone call. But at home, we really don't talk shop. We left work at work and, we decompressed. But I have a 5-year-old and an almost 7-year-old. So we're getting in the garden, we're getting dirty, we're going out, we're camping a lot, we're always outside in nature as much as possible. And that's really like, put me on a beach anywhere. Like that is my safe space. And that's really how like I take care of my mental health. I have a really core group of friends that are always there to listen, whether or not they understand.
That's okay.
Besides the point. It's an extra bonus when I do get somebody that does understand the nuances that kind of come with nuclear medicine. And I've stayed in touch with a lot of the techs from other hospitals I've worked at. I have a group of ladies that were nuclear medicine techs, and we get lunch routinely. And that's always a really good touch point too, because those are the people that are down in the trenches with you, knowing what's going on and what problems always arise.
Yeah.
And just gives a good vent session.
Absolutely. Good.
Yeah.
I'm glad to hear that you're doing all that.
Yeah. Oh my gosh, it's so important. I don't think, mental health is inherently so hard. We don't have the care and the people to provide the care that we need it. But it's so much a huge part of this. If your mental health is tanked, you're physically going to see the effects of that. Mm-hmm. Absolutely.
Yeah, it's a huge factor, especially for medical providers.
Absolutely, yeah.
I know we talked about your connection to New England Cancer from back in the day.
Yeah.
And you also do have a personal family connection to cancer through your aunt.
Yeah.
And tell me about her.
So my aunt was doing her usual screening mammogram and kind of found something that she didn't love and had kind of asked to, get in and get that done. Unfortunately, after biopsying and everything, she had gotten the breast cancer diagnosis. And was with a different hospital system, if you will. One I had worked in and knew, but I knew that I really loved working with New England Cancer Specialists, and I knew all the resources that we had. And so I think, when people get a cancer diagnosis, they, the primary care, whoever puts in the referral, and it's just to an oncologist, and they run with it.
Sure.
I think that people don't realize that they can just reach out to a New England Cancer Specialist, though. You don't even need a referral.
You don't. You can call the number.
Just call a number, fill out the form on the website. It's really easy, and they're really good communicators. And so I really encouraged her, maybe aggressively so, to reach out.
/pushed.
To reach out. And I had reached out to our intake people and was like, hey, just so you know, this is going to be coming down the pipes. And long story short, she was actually the last patient seen at our old campus.
Oh, in Scarborough.
In Scarborough, yeah. So she got in with Dr. Patelli, who I had worked with when I was originally with New England Cancer and have taken care of many of her patients. And I was like, this is who I need you to see. Like, I want you to be seen within my workspace because this is who I trust. This is who I would want to go see. This is who I would send my daughter or my mother to. And so glad that I did. She had such a wonderful experience with Dr. Vitelli, and they always kept communication. She lives pretty rurally in Western Maine, and so they were very willing to coordinate with other facilities locally with her. And she's been in remission ever since.
Oh, that's fantastic.
Yeah, she had, she went through the rough stuff, having to have the infusions and the meds, and she'll have, the long-term meds that she needs to be on, but otherwise has been in the free and clear, living a normal life. And
that's wonderful.
I just don't feel like she would have gotten that really special care where she was at originally. Not for any fault of their own, other than the fact it was a big hospital system. And so, I was really, really glad to have the resources and the to just give her a second opinion.
Yeah, an alternative.
That she really loved and appreciated. And I was with her for every appointment at the beginning for sure. If anything came up. So that's my New England Cancer Specialist
that's actually
story.
Almost identical to my own story, apart from the encouragement / pushing, because my aunt is a patient of Dr. Batelli's too. Early detection for her breast cancer and is thriving. She actually came to our recent survivorship event that we held in June for Cancer Survivorship Month, and we had a photo booth there where you could get your picture taken with your doctor. And she's so funny. First, she didn't want to come to the thing because my cancer wasn't that bad, which it's like,
I know.
Cancer is cancer, which we really did try to emphasize at the event a lot for people, because they do have, kind of this imposter syndrome if their story is maybe not as dramatic as another person's story or something. So first I had to convince her to come. Then she's there, and I caught up with her, and I'm like, let's go get your picture taken with Dr. Patelli. I don't want to bother her. She's literally here for exactly that purpose, and she wants to, see everyone that she can.
Absolutely.
And she honestly was so happy with how the event turned out, meaning Dr. Patelli, but my aunt as well.
For sure.
And she's the queen. It's just,
she really is.
No two ways about it.
I think as somebody who provides healthcare, we kind of have like this mental list of, maybe I don't want them to ever operate or treat me. Or like, you just, it means a lot to me as somebody who works in healthcare to hear, this is where I would want my own loved ones to be seen.
Absolutely.
And the resources that New England Cancer Specialist has, bar none. I mean, we've got the Dempsey Center in the house now. We have Reyes right there for all your imaging needs. We have all of these physicians with so much combined knowledge that even if it's not, the queen of breast cancer herself, we have all of these other really great services that we can offer. And if we don't have the answer, we'll figure it out and we'll get it together.
Yeah, we'll help you find out what the answer is. Yeah,
right, absolutely. If that means deferring down to Boston, sometimes that's still the scenario, but I think we can do a lot of in-house stuff too.
Yeah, 100%. Thank you.
Yes,
I love that story. We're trying to get big on the second opinion thing.
It's hard, and you know what? Patients don't know that they can do it, and I think a lot of patients, in my experience, think that they're going to hurt the feelings of the first opinion.
I know.
And they're like, but they were so beautiful. They were so nice. I'm like, well, they need to be.
Yeah.
That's a minimum.
That's table stakes.
But also, everyone has different knowledge. We've all acquired this knowledge from different places and people and our experiences. And so to get a second opinion a provider should never be offended by, ever. Even if it's a second opinion with a New England cancer specialist themselves.
That's true.
I see those in-house, shifts all the time, Sometimes personalities clash. That's fine. We've got somebody else who has a great sense of humor and will keep it more lighthearted, or somebody who's just facts. This is the game plan. We've got those too. So it's not a one size fits all for providers. You need to be really confident and trust your team.
That's
and
very
if you
true.
don't, do not be offended to ask for a second opinion.
Yeah, second opinion.
Ask for a third. Ask for a fourth.
You
It's
can get
your body.
as many opinions as you want.
Absolutely. Yeah. And you should never worry about other people's feelings in those scenarios. You put yourself first.
Yeah, and any provider worth their salt is not going to be upset
Absolutely.
by that.
And I promise, if they're a provider in Maine, they have other patients, lots of them, and it's not from a lack of business perspective by any means.
That's good. Well, Kersti, I can't thank you enough for agreeing to come on the podcast. I know I said that already at the beginning, but I'm really just grateful that you had the time and were able to take the time to talk. And I definitely want to have you back, once we kind of are ramping up our talk and discussion about the research department and how that's going to kind of feed into your work. I think, as you said, the impression that I get from everyone at New England Cancer is that this is moving so quickly and advancing so amazingly.
It really
that
is.
The sky's kind of the limit.
Yeah, I would love to come back, especially after we kind of have boots on the ground in the research field. We're really in the baby step stages. We don't have anybody, screened or enrolled yet, but there's some really cool things coming down the pipes. And I think I really think the industry as a whole is going to grow at an incredibly fast rate with this targeted therapy. And I think we're going to be able to definitely broaden, the cancers that we're treating. I know prostate cancer is kind of the main focus within the program, just because Pluvicto was the first FDA-approved targeted therapy.
Yeah.
And so that really opened the floodgates. And I imagine that we're going to have a lot of success with it the more and more stuff comes down the pipes.
Yeah, I think so. I think it's going to be far from the last. So.
Oh, absolutely. Yeah, no, this is just the beginning.
Okay, great. Well, here's to the beginning.
Can't wait.
Thank you so much.
Thank you.
Thanks for listening to this episode of On the Subject of Cancer. If you are listening and heard a piece of yourself in this conversation, whether you're a survivor, a caregiver, or someone still finding their footing, we're glad you're here. Cancer can be isolating. Conversations like this one with Kersti remind us that even when the experiences are different, the feelings often aren't. If you have a topic you want us to cover, please send us a note to the email address on the screen, or visit us at our website, newenglandcancerspecialist.com. This has been On the Subject of Cancer.